Hello, so today we'll present our topic on sports injury. So this is our table of content. So first we'll start with shoulder dislocation. This is the anatomy. So shoulder joint is a ball and socket joint composing of humerus head and the glenoid cavity, where the head of the humerus has a larger surface area than the glenoid, which led to its small contact area between the joint, making it highly mobile, but however, with less stability. And this is the anatomy of inside the joint. For shoulder stability, it's comprised of two main categories, like static stabilizer and dynamic stabilizer. So for the static stability, it came from the bones and the ligament, whereas the dynamic stability, it came from the muscle used in the shoulder motion. These are the listed stabilizers. So next we'll talk about the mechanism of injury.
So dislocation, that is bimodal distribution. It's very common in the young and very common in elderly. But the pathology is different. Do you know what is the main problem in elderly and in the young?
Main problem in
Static dynamic stabilizer. What is dynamic? For example,
dynamic is like the rotator cuff.
The muscles.
Yeah.
Right? You see, every dynamic is muscle, right? Muscle deltoid, periscapular muscle, long and bicep. So dynamic is more important in the elderly patient. In elderly they tend to have rotator cuff problem, right? So many times patients have torn rotator cuff and the shoulder unstable and dislocated. But in the young, the rotator cuff always good, right? So the problem is the capsule, the labrum, right, on the bone anatomy. So in the young, you always see good rotator cuff, but that capsule, that labrum. Yeah. But in the elderly, dynamic is more important. Yeah. Okay, good. Next.
So there's three types of mechanism of injury. So there's like anterior dislocation, posterior and inferior dislocation. So for the anterior dislocation, it's the most common one. It's about 90% of all shoulder dislocation. So the patient would fall on an outstretch of hand with abducted externally rotate and extended arm. We can call this a throwing position. You can see on the picture on the right, this is the throwing position, or the patient can have direct flow from the posterior humerus to this position, and it can cause anterior dislocation. The humerus will come to the front. For posterior dislocation, the patient can have history the blow to anterior portion of the shoulder, axial loading of abducted and internally rotated arm or arm sling position in this picture, or the patient can be seen with like following a seizure or electrocution. The patient can also have posterior dislocation too. For the last mechanism is for the inferior dislocation. It can be from axial loading with arm fully abducted, and it's a forceful hyperabduction of the arm. The patient have like history of falling, sudden grabs an object above their head, and it can cause inferior dislocation of the shoulder.
Is it common?
Inferior is less common.
Very rare. I have seen only two. Very rare. But people have seen inferior dislocation.
Oh,
So
okay.
you can share your case to the students. Exam.
Okay ครับ
You can send to me or you send to the group. I add you in the group. So you share the feature to the group, okay?
โอเคครับ
So for the physical examination, we start off with inspection for the position of the shoulder and the asymmetry between like both shoulders, and palpitate the point of tenderness of the shoulders. And also we test for the range of motion to see if there's any limitation, and also the neurovascular, like the axillary nerve and brachial plexus. For like specific for anterior shoulder dislocation, we can see prominence of acromion in this picture, like this. And for the dislocation, there's Hamilton ruler sign and Dugas test. For Hamilton's ruler sign, the deltoid will flatten due to the humerus head anterior dislocate, and the ruler can be like side on like this. For the Dugas test, the patient cannot bring their hurt shoulder, like cannot bring their hand to the opposite shoulder because it hurts.
Not touch the opposite shoulder.
You cannot touch.
Yeah. So that is adduct, internal rotate, right? That means
Yeah.
the patient cannot adduct and internal rotate. Position will be like the picture, there will be a bit abduction and slightly external rotation.
So another one is test for instability. It's called apprehension sign. It's the sign where we will abduct the arm about 90 degrees with passive motion to the maximum external rotation of the arm, and then forward pressure applied to the posterior aspect of the humerus head. If the patient felt there's any pain or instability in the shoulder, this sign is positive.
Where did you get this picture from?
I got this picture fromของพี่อีกทีนึง because I cannot find the exact picture.
Long time back. 30 years.
I think so. So next is the posterior shoulder dislocation. So in this picture, we can see prominence of posterior shoulder with flattening anteriorly, like the shoulder come here. And the prominence of coracoid process, you can see like here it's protruding. And the sulcus sign is the dimple inferior to the acromion. There's a little dimple here, inferior to the acromion in this picture. So other tests are the test for instability and test for laxity. So there's jerk test and posterior drawer. For the jerk test, the patient is in a sitting position and the examiner will put one arm at the scapular and then the other hand will use for flexion, abduction, and internal rotate the shoulder with applied axial load. If the patient felt pain at the posterior side, it's positive. And for the posterior drawer test, the physician will place one hand to stabilize the scapula with the thumb on the patient coracoid process, and the other hand is used to apply pressure posteriorly, like in the.
You know, instability test and laxity test, is that the same?
I don't think so.
No. Instability test produce pain always, right? Like the anterior apprehension, this is for anterior, that would produce pain, like shoulder is getting out. Patient can feel like it's getting out. This is the jerk test, is the posterior instability test, you know, that would produce pain. Yeah. But the laxity test is like you do drawer, like you do anterior drawer, posterior drawer, but the shoulder also have drawer test, but not produce pain. When you perform anterior drawer for the ACL, the patient will have no pain, right? So that is laxity test. No, instability test always produce pain. Like pivot shift, the patient have pain, right? That's produce the feeling of subluxation, same like the shoulder, right? So laxity test is a test that you can check there's some loosening of the joint, but not produce pain. Okay. So you should perform the laxity test before instability test. Yeah.
For the imaging, the most common imaging in shoulder dislocation is plain film. It's used both before and after close reduction. There's AP transcapular Y and axillary view. So axillary view is not routine due to it can induce pain from adduct shoulder. So this is the picture for anterior dislocation. You can see in the AP, the humerus head is dislocate from the glenoid of the scapular and now inferior to the coracoid process of the scapular here. And in the transcapular Y view, we can see the dislocated humeral head in located anterior to the glenoid and inferior to the coracoid process here. And axial review is not recommended in anterior dislocation. But for the posterior dislocation, axial review is kind of the gold standard for diagnosis in the posterior shoulder dislocation due to the AP and transscapular Y can cause misdiagnosis. So in the axial view, you can see the dislocated humeral head is positioned anterior to the glenoid fossa.
So the posterior is common miss. If you look at the first picture, see first picture?
Looks kind of normal.
Yeah, it looks like very normal, right? So it's not that obvious like the anterior dislocation. So and also the deformity is not obvious. Patient can do Luca test. Okay, it's different from the anterior, so you can miss it. Yeah. So the thing that you can see is that the patient may have flattening of the anterior part, but if the patient have high BMI, you cannot see any difference. You know? And the arm is not like deformed like the anterior dislocation. No sulcus sign, no liver sign, no Duga sign, right? So it's common miss.
And also in the AP, the glenohumeral joint is widened and the humeral head is taken more rounded. So it's called a light bulb sign, like in this picture. It's kind of like a light bulb.
So your video is not adjust the video. Make it up. A bit. Yes, that's right.
Okay.
And you should away. You should not use it.
So for the management, so if there's no fracture, close reduction should be done after adequate pain control and IV sedation. And also we need to check for the neurovascular both before and after reduction too. If the patient arm is reducible, there should be short-term immobilization for like arm sling immobilization for 1 to 2 weeks, and also repeat imaging should be done to confirm the reduction too. And also if irreducible, we will go to the one with the fracture. So if irreducible, we need to do open reduction and just like internal fixation. If there's fracture present, we need to do the open reduction and internal fixation.
So most of the case if the patient comes you can reduce it. Unless there is a fracture also, because fracture dislocation, maybe it's not easy to reduce it. So if you want to reduce, you need to do it in operating room. Okay? But most of the dislocation, you can do that at the ER. So now talking about the reduction, right?
We'll go to the close reduction technique. The first one is called traction counter-traction technique. Is when the patient is lies in a supine position and given analgesic and sedation. The physician then hold the patient's dislocated arm and pull with their body weight. This is called traction. It's this one. And for the counter-traction, the sheet is wrapped around the patient's axilla and the chest wall, which is held by an assistant on the opposite side of the shoulder along the scapular plane. The assistant then pulls the torso in the opposite direction of the traction. The physician pulls the arms in a supination along the longitudinal traction together with abduction until the shoulder joint is reduced. When the shoulder is reduced, the physician will feel the small pop sound when like the shoulder is inside the joint and the shoulder is back into the socket. In case of the patient with presentation of rotator cuff tears, another force is needed on the lateral side to reduce the shoulder due to the rotator cuff acts as a head depressor to help guide the shoulder back into its socket. However, in patient with rotator cuff tears, there's no humeral head depressors, so another force at the lateral side will help to guide the shoulder back into its socket. So another one is called Milch maneuver. So Milch maneuver, it can be used for recurrent shoulder dislocation without the need of intravenous sedation or general anesthesia. So it starts with holding the patient wrist and slowly abduct the arm, kind of like in a supination position, and use steady, gentle traction throughout. Then the humerus will slowly glide back into the joint. So after reduction, the patient can do the Duga test, and now the patient should be able to place the hand of their injured arm on the opposite shoulder. So this is
See
the,
that the patient is awake, right? He
Yeah.
can talk to me.
Yeah.
So this is good for the patient have the multiple dislocation, and patient must be good cooperation. So the trick is that you just traction in the dislocation position, and gentle, you see, gently supinate, right? Okay, for abduction is where, and finally the shoulder will pop in very gentle. But patient needs to have good cooperation. So we call this Mills maneuver. We not recommend to do this in the patient have to
pin.
rotator cuff tear or they have the big bone defect. So you can create a fracture. You know, elderly patient also corrosive. When you try to do abduction, so sometimes you can create a fracture. So I think I recommend you to do traction, counter traction for general practitioner, etc. Because you know, this is we call leverage technique. Yeah, you use that like the lever arm to elevate the shoulder. But the traction base is safer. Yeah. The next.
So the other maneuvers are including Stimson and Hippocratic can also be used. So the Stimson is when the weight is used to glide the humerus back into the joint via gravity. So in this picture, the patient is lying in prone position with affected arm hanging off the bed with suspended weight on the affected limbs around 5 to 10 kilos. Then the gravity then creates a gentle, continuous traction, allowing the shoulder muscle to relax, and then the humeral head to slide naturally back into the glenoid fossa. This maneuver does not use any human force, so it's less likely to produce any risk of neurovascular injury.
But the problem of Stimson is that the patient can falling down. Okay? It's not
Yeah.
easy. You need to find a very special table. See, the table must be very high, right? Because you hang the arm down and you have traction. So it should be like this high. Okay? So not easy to find that at the emergency room. Okay? And you need to stabilize the patient very well. And in front position, is if you see that the patient is difficult for you to assess the airway of the patient. If you do some sedation. So it's good, but I think not so practical. You need to protect the patient very well. The patient needs to be on the edge of the table. And the right picture, you should not do that. So the name is so antique, right?
So Hippocratic is similar to traction counter traction technique, yet the counter traction is used and the physician will use the leg to
foot.
the heel to hold the traction. So it's less favored today because it carry higher complication risks, including axillary nerve injury, brachial plexus injury, and fracture to the humeral head or the neck.
The problem is that your foot is in the brachial plexus area. And damage the brachial plexus.
So it's less used.
Right,
Have you done it before?
Have you done this before?
I think only once when I was in provincial hospital. So the good thing is that if you have no assistant, right, can do that. But right now we have so many techniques to do that. So they recommend not to do this anymore. Okay.
So this is for the close reduction. For the advice, we should advise the patient for the recurrent shoulder dislocation. Factors are including the patient's age. So if the patient have less age, the higher the rate of the recurrent. Also, if there's any bone defects or they will go to returning to contact sports or overarm throwing sports like American football, rugby, or hyperlaxity, male, and more than 5 years after the first shoulder dislocation, they will have higher rate of recurrent shoulder dislocation. And for the complications, we should advise the complication of the axillary nerve injury, rotator cuff tears, and frozen shoulders. And the patient should avoid external rotation of the arm and adduction for at least 1 to 2 weeks. So we usually, after close reduction, we usually give the patient arm swing back immobilization.
So what do you advise to the patient of the first time dislocation?
So, หมายถึงว่า
Yeah, first you need to tell the patient you have the chance
chance
of
of-
second dislocation, second, third, fourth, right? So first you need to tell the patient this is not maybe not the first time. And the incidence of the ligament dislocation is very high, right? Depending on
the
the
age,
age and also the
the bone
activity
activity.
of the patient. If the patient is very active, if they are the overhead athletes, yeah, they tend to have the dislocation. If the patient younger than 20, about the percentage, 95%. Yeah. So if the patient is very young and very active, so they tend to have the second dislocation. Okay. And the patient job, if the patient have the job like they are firefighter, they are cliffhanger, something like that. If they are very active and their job is very risky, you need to recommend surgery for the patient because they have very high chance that is very risky for their life, right? If they have second dislocation. Okay.
So the patient should be like do rehabilitation too. This is
Strengthening the dynamic stabilizer. When they have dislocation, they have torn labrum, and those labrum may not heal properly, right? So if you have good dynamic stabilizer, good rotator cuff, the scapular muscle, the chance of the ligament will be less. Okay? Tell the patient to avoid the risky position. If they have anterior dislocation, this is the risky position.
Throwing.
That external rotation. Okay, very good.